Thank you very much. So thanks very much for inviting me. I'm a bit like Annette. The first time I got invited, I was like, oh, is that really for me? That must be spam. Anyway, thank you for inviting me. So I had a little trouble figuring out what to talk about, partly because, the organizers didn't want to constrain me or guide me too much. And also, I haven't been to this meeting before, so again, I wasn't quite sure. So hopefully, I wasn't sure, too high, too low, whatever. If it's off target, forgive me. But here we go. Okay, so as an overview, so obviously the problem is that treating active TB doesn't seem to be enough in terms of eliminating or reducing TB. The solution, everyone seems to think, is treating latent TB. And what are some of the problems related to that? So there's the diagnosis, the treatment, the health system scale-up, what I'll talk about the cascade of care. There's also who should be treated, how often they should be treated, and then I'm going to finish talking a little bit about reservoirs and resurgence, because when we talk about treating latent, you have to treat every last latent bacteria in the population. Okay, so first of all, what's the current global burden? I'm not going to dwell on this too much. I'm sure you've all heard this many times. 25%, it's an estimate, maybe from one of you in the room, I'm not sure. That's a lot of people. And if 10% develop TB, that's a lot of people with active TB. So first of all, here's my rough estimate. This is not modeling. What's the current impact of treatment on the global burden of latent TB infection? So this is a fairly simplified schematic of how we're doing so far. Okay, so diagnosis. I'll just touch on the basics. So TST versus IGRA. So really we have two diagnostic tools. The TST, the good points, there's several of them. It's relatively inexpensive. It can be done almost anywhere. If you have a cooler, you can travel. It's fairly simple to learn, and it is definitely reproducible. The bad points is poor specificity, suboptimal sensitivity affected by immune deficiency, so the very conditions you're interested in affects the TST. It does require proper technique, and it's an old test. I think that's probably its biggest weakness. It's just an old test. It was first described in 1908, and either in Germany or in France, depending on which country you're from. But it's an old test. The IGRA, so good points, very good specificity. It's designed, cleverly designed, I might say, to be specific. It is specific. It has no adverse effects because you don't inject anything into people. It's lab-based, so it should be more objective. There's a technician somewhere who never sees the patient reading, and it's a new test. And again, that's a very important advantage. It's new. The bad points, suboptimal sensitivity. It's affected by immune deficiency. Accessibility is a problem. You need a lab. It's more expensive, and it's not reproducible on serial testing. So here's a more simplified version of the TST versus IGRA debate. It goes something like this between two people. But as it says below, Bob kept missing the point. So what's the point? So the point really is that both tests, if you look at the incidence of active TB after a positive test, we know with TST, what's the incidence? It's debatable. It's maybe 10% cumulative lifetime. And the same with a positive IGRA. This is in the first year or two after in household context. We think of a high-risk group. And all of these estimates are 9 per thousand, so a bit less than 1%, up to a little over 2%. So the key point of our current diagnostic tools is that after many studies with IGRA and many studies with TST, they're not that good at predicting who's going to get TB. Okay? You have to treat a lot of people to hit the one somewhat randomly who's actually going to develop disease. And that's a big limitation when you're trying to model something and you're thinking about cost effectiveness or just modeling the impact on anything. You always have to factor in this kind of 1 in 10. You got to treat 10 at least to prevent that one with TB. Okay, so who should be treated? That's kind of the next issue. And so when we think about who should be treated, you read guidelines. Guidelines are usually written about individual benefit. but modeling is usually about public health benefit. So you have to think, sort of look at the guidelines, but also think, okay, what's the public health impact? So when we think about individual benefit, we think about what's the relative risk. And again, the relative risk varies a lot depending on the study, and this is taken from a variety of sources. And so there's obviously quite a range of relative risk, but towards the top are all the ones, in fact, it's interesting that WHO is now recommended. So things like silicosis, TNF-alpha inhibitors, renal failure, transplantation, things on your x-ray. And then towards the bottom are things like diabetes, low body weight, cigarette smoking, heavy alcohol use. Again, many of these estimates come from systematic reviews. And as I said, there's obviously quite a range, okay? So if you look at that, you'd say from an individual point of view, risk-benefit point of view, you're going to look at the top of the graph. But from a public health point of view, now you have to worry, well, how common are these problems, right? So when you do that, which was actually done by Knut Lonroth some time ago, first of all, malnutrition, despite its low relative risk, is by far and away the most important risk factor from a population attributable fraction point of view. So if you're modeling, you got to think about malnutrition. But then again, what are you going to do about malnutrition? That's a bit of a problem. Smoking and alcohol combined, second biggest problem. Someone, actually I forgot, it was in the ERJ, and GB Migliore was involved, but population attributable fraction, a more recent estimate, just from smoking ranges from 9% in sub-Saharan Africa up to as high as 28% in the former Soviet Union countries in Eastern Europe. So cigarette smoking, again, depending on the region, can be a very important individual factor. But remember that its estimate of relative risk is quite small, okay? So if you can get people to stop smoking, of course, there's a lot more advantages than just the TB advantage. But obviously, if anybody's ever tried to get people to stop smoking, or anybody happens to have ever smoked themselves, they know how difficult it is. So it's not an easy thing. Easier perhaps to model. HIV infection is the one disease that's kind of at the top of both lists. So obviously an important one to model. Diabetes and all the other medical illnesses put together. So renal failure, the infliximab, the TNF-alpha, transplant, whatever. It all comes out to less than 10% in terms of global impact. So important individually, maybe more important in North America and Western Europe, but clearly not a big strategy if you're trying to have a global impact. Okay, so that's who. Now, how should you treat it? Okay, so first of all, what are the options? So there's 6 months of INH, which is kind of the, how should I say it? The Volkswagen approach put forward by WHO. Then there's 9 months of INH, more effective but longer, 3 to 4 months of INH and RIF, and other options. I'm going to run through them very quick, a couple of them very quickly. So first of all, Frank, this is for you. So the Eastern European trial was the largest trial, 28,000 people in total, approximately, run in the 1970s, and you see different durations of INH. And among the completer compliers, so people who took INH for 12 months, 93% reduction of risk over the next 5 years relative to the placebo group. This is one of the older trials when they still allowed, or placebo controls were ethically permissible. So very valuable. INH for 6 months, you see, is quite different, okay? Now, the reason that INH for 6 months is favored still and is recommended widely is the top group. So when you look at all participants, there's much less difference between 12 and 6. Why? Because, of course, people drop out every month. But if you ask an individual patient, so I've never had a patient say, "Doc, if I don't take it, will it work?" They don't ask that. They actually ask, "If I take it, will it work?" Right? And so that's usually what you give as advice. You say, if you take it, then it's, 12 is better than 6. And in fact, 9 turns out to be the most efficient kind of cut point. And 9 comes from George Comstock's analysis. So all this to say that 6 is clearly inferior to 9 if you take it. and 12 is the gold standard. Okay, but the downside of INH, which is well known, is the mortality from INH hepatitis, which was much higher in earlier years and has come down substantially because people have learned how to identify who's going to get toxicity. It's mostly through patient selection. Some of it may be through closer follow-up. Okay, but still deaths, or liver deaths, as they're now termed, in the year of liver transplantation, continue to occur. We did a population-based survey in Quebec using the Quebec provincial database, which is 99.5% of all people in Quebec. We saw 1 to 2 liver transplants per year. People given INH. About 1,000 people a year getting INH, 1 to 2 liver transplants per year. For, again, database studies are difficult because you can't always be certain, but there was no pre-existing liver disease in the 3 years prior to INH, and the INH was given and liver transplant followed within the year. So liver deaths continue to occur despite everything. Okay, so moving right along, there's INH rifapentine, which is new. INH is old, therefore bad. Rifapentine, INH rifapentine is new. So this is the study from TB Trials Consortium, Tim Sterling and others. And as you see, a large-scale trial and excellent efficacy among those who took the drug, the 3HP, 3 months INH rifapentine, 0.1% risk of active TB, so 1 per 1,000, lower even than the 9-INH group, okay? And very good completion, as you see. But the adverse events were a bit of a drawback because despite the fact it was only 3 months and 12 doses, the overall rate of grade 3 to 4 adverse events was similar, and drugs stopped were actually higher for the 3HP and less for hepatotoxicity, but more for this hypersensitivity phenomenon, which actually resulted in hospitalization more often in the 3HP arm than the 9-INH arm. So an important caveat in terms of safety, not the same problem, but a different problem. So I felt I couldn't resist the opportunity, but to talk about some recently completed studies that involve some collaborators here in the room. A randomized trial for RIF and 9-INH in children and adults. And very briefly, so this is grade 3 to 5 adverse events, drugs stopped. And I'm just highlighting 2 areas. One is kind of total, judged possibly, probably related by an independent adverse event panel. So significantly lower with 4 RIF, and hepatotoxicity, again, a rate of 3 per 1,000 of grade 3 to 4. No hospitalizations, actually, in either arm. In terms of active TB, identical rates of active TB in adults, actually lower rate of active TB in the kids. So conclusion for RIF was significantly safer, particularly in terms of hepatotoxicity, significantly better completion. I didn't show that in adults and kids, and certainly non-inferior. We conclude non-inferiority for 4RIF in terms of TB prevention in adults and kids. So here's my schematic of safety and efficacy for LTBI regimens. So you see that 9-INH and 6-INH I've crossed out now. I want you to start forgetting about those regimens. 3HP and 4RIF all appear to have as good efficacy as 9-INH, so around the 90% mark as was estimated previously against placebo. 3 to 4 months of isoniazid rifampin in the meta-analyses has generally been about the same as 6 months of INH. The comparators have varied, and safety has been similar to 6 months of INH. So it's a bit less than the, in terms of efficacy, than things like 3HP or 4R. Okay? Obviously, this is my personal schematic. Others might change that slightly. Okay. So now the next thing that is kind of troublesome about latent TB is this question of how long do you need to treat them? Why people seem to get TB after taking latent TB treatment. So I thought I'd go back to some of the older literature first. So this again is studies done in the Alaska Eskimos, or Inuit as they're called at least in Canada. And George Comstock and others did a series of studies and then went back and looked 19 years later after the randomized trials were done and concluded in this paper that the protective effect of INH was shown to persist for more than 19 years after INH was taken, and the magnitude of effect was proportional to the amount of INH. Because in these trials, some were given for 3 months, 4 months, 6 months, 8 months, 12 months, and so on, due to partly geography and climate and accessibility. Anyway, for a variety of reasons. So this is partly what allowed him to say 9 was the optimum, but this also, you could conclude the benefit was there even 19 years later. So that's about as long a follow-up as you'll see. Definitely, I'm not aspiring to that kind of follow-up personally. So again, the conclusion taken directly from their abstract is that the decrease in risk of tuberculosis produced by INH preventive therapy is lifelong. So that's kind of the good news. Now the bad news comes from South Africa, where, and not just South Africa, but other trials, which have consistently shown that the benefit of INH is present during therapy, but then seems to evaporate soon after therapy is stopped. So here's kind of a nice example. Gavin Churchyard, this was a large-scale trial among HIV-infected South African gold miners. So they have silicosis to some degree, maybe subclinical, but at least silica exposure, and HIV. So they're very exposed. They're living also, they're working in the underground mines, and they're living in these crowded conditions above the mines. So it's the most propitious circumstances for TB and the worst for the human hosts, you might say, imaginable. But in that setting, during the time of INH, which is the blue, the rate of TB was substantially lower than the green, which is the placebo group. But as soon as INH was finished, it was 9 months of INH, as soon as the INH was over, the rate of TB became the difference was non-significant. Looks like there might be some small difference, but really non-significant. So this suggested that, at least in this setting, INH was great, but you had to keep going and going. And there have been other trials looking at 36 months of INH, so-called lifelong INH. And the difficulty there is, of course, the same problem of keeping people on therapy. So they slowly drop out. So that practically it's quite difficult. So I would say that the contrast between the two studies, two very different populations and so on, but it's a bit unanswered as to what the benefit of INH and how long it lasts in terms of, it's a very key issue, obviously. So how long it lasts is a key issue and is, to my mind, not certain. Okay, another thing that Annette touched on is this cascade of care, sort of a health system approach. So let's for a moment set aside the problem with the diagnostic tools and the treatment and how long to treat and even who to treat. Let's just assume we're going to go ahead and treat some group of people. But now let's say we choose contacts. They're a nice high-risk group, fairly well defined. But what's the difficulty when you think about latent TB management? Because if you're modeling scaling up latent TB to really have a public health impact, you have to think about a health systems approach. And the difficulty is this, that when you're doing latent TB, you have to put a whole set of operations into place. You're not just giving INH or rifampin. You're not even just doing a tuberculin test and an X-ray and a symptom screen and then whatever. You have to find people, get them in, get them identified, get them tested, da-da-da-da-da. You have to get them through a whole cascade of care. And so this is kind of a schematic, but here is, if you will, the cascade of care, showing like a true waterfall of steady decline in numbers and percentages. So this was actually based on a systematic review we published a couple of years ago. Hannah's a PhD student at McGill. So starting with the group of contacts, this is actually intended for screening for various conditions, who's actually tested, then those who are tested who get a result, because there's always dropouts. People don't come back for reading, they get an IGRA, they don't come back for a test result. If their test is positive, do they even get to the next stage of seeing someone about that? Then, if they get to the next stage, do they complete the medical evaluation? And this is, the chest x-ray is one big barrier here. If they get through that, they have to get to the provider. And lo and behold, we've seen, and Annette has some nice examples, where you fix everything. Finally, everybody's coming in, everybody's getting screened, everybody's getting x-rayed, everything is working, and then you go back 3 months later, no one's been treated because it turns out the doctors don't agree with treating. That's a bad idea. So you have to fix that too. So that's another point where people drop out. And then, of course, you get all that fixed and people still don't agree to start even. They say, no, not for me. Or they've read something on the internet or whatever. And then finally, of course, they still start treatment, but they don't finish it. All this to say that all the best regimens in the world are really fixing just the bottom corner. Okay? You have to get started for the regimen to actually have any impact. And getting people started turns out to be a much bigger step and accounts for a lot more losses. So, all this to say, of all estimated to have LTBI, less than 20% complete treatment, and there are various steps along the way where large groups of people get lost. What are the implications? So first of all, the losses before starting. So no matter what regimen, you want to model one regimen against another, forget it. You got to model the whole health system approach from the start. Okay? So a comprehensive cascade of care approach is important to consider, and you need to think about it either in terms of costs and complexity or in terms of the losses. Okay, so next, moving quickly on to a different topic. So again, an alternative approach, thinking outside the box, which is generally a good thing, except if you have a cat, in which case you want the cat not to do that. Okay, so this thinking outside the box goes back to this whole thing of malnutrition and all these other risk factors, the determinants, smoking, alcohol, right? Healthy lifestyle kind of determinants. So before streptomycin was discovered, in England, they decided to try an experiment, a kind of social experiment, to see if this would help prevent TB. So this was a comprehensive experiment to alter life conditions of TB patients and their families. They set up a whole village with workshops. They actually built cars. They had, to be admitted, one of the parents had to have active, open cavitary TB. And the children moved in with their parents. They were monitored for TB very closely. And the interventions were really just better housing, employment, nutrition, and monitoring. No TB drugs, and at that time, no BCG. There were two cohorts of kids. They were, again, the primary outcome was measured in kids. The admitted group, so they were born outside. They moved in with their parents. And then there was the group that was born after they moved in. They lived there for an average of 7 years. So this is really fascinating because you have the admitted group, so 231 kids moved in. Before they moved in, so they were all little kids, 13 had a disease, 1,500 was the rate of disease. Obviously, the Papworth born doesn't have a pre-Papworth period. Then they're in Papworth, and you see the rate of disease is already much lower, but lower in the group who are, in fact, younger, therefore actually more susceptible, because inevitably they're 0 to 7 in that age range, and the others are mostly, 5 and above. So they're actually at lower risk, still have higher rates of disease, but look at the rate of infection. the rate of infection based on TST and X-ray, granulomas appearing, was the same in both groups. Okay? So it wasn't preventing infection at all. It was preventing disease, just really housing and nutrition. Hard to know what the housing was doing since the infection rates were the same. And then post even, although the numbers were very small, too small really to draw much conclusion, but in the few that they managed to follow, no disease. Okay? So that's kind of an alternative approach. Tackling risk factors, at least someone's had a look at what would happen in a sort of quasi-experimental way. Okay, and so finally, so one thing that interests me in thinking about latent TB is, one manifestation of latency is obviously when TB develops. And latency in a population is when something happens to a population and you see a resurgence of TB. You say, well, presumably there was a lot of latent TB there. That's at least what I would think. So one sort of the earliest evidence of resurgence related to kind of external events is TB mortality, United Kingdom. Same graph. So these two blips, one of which is very pronounced. I'm not sure if you can read the scale at the bottom. Basically, those two blips in the curve are World War I and World War II. And different European countries have done the same, and the blips are there. The Netherlands, Germany, same exact. Interestingly, after the blip, the curve continues. So it didn't have a long-lasting impact, but it had an impact, short-term. So it wasn't, from this I infer it wasn't transmission. Right? It was either, what was it, stress, was it malnutrition, what was going on, I'm not sure. But something affected the entire population. There was a blip in occurrence of disease and mortality, and then things went back and carried on. Another resurgence is sub-Saharan Africa, especially East Africa. East Africa, TB rates were pretty stable, maybe going down a little bit, but not dramatically high in Tanzania and Kenya and Uganda. And then HIV hit, and the rates doubled, tripled, quadrupled, quintupled, just went up and up and up and up and up. Okay? And so this, we think, that's easy. That's HIV. That's all HIV. And so far we haven't really, although it's begun to turn down a bit, we haven't really seen the same phenomenon as in Western Europe by any means. Then there's New York City. So again, New York City, rates were going down, 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 and then suddenly in the early 80s they started to go the wrong way. It seemed as though no one kind of noticed till the late 80s when they were really going the wrong way. And here, theories are a bit more mixed. There's certainly some HIV in there. They're probably not immigration, because this was mostly US-born phenomenon. So what exactly all that went on in here is a little less clear, and there's various theories. What about Russia? Again, after sort of the breakup of the former Soviet Union, there was a dramatic resurgence in TB with a complete reversal, nice downward trend for a couple of decades, and suddenly it just shot up very steadily. Mortality, case notification, etc. So what was that about? So actually, Olivia and I and others looked at this with some interest, and kind of just looking at general indicators, what was going on. So Russian Federation, the change in TB rates, actually we looked at all countries, and the biggest difference between the Russian Federation and all other countries was the difference in life expectancy. Where life expectancy in Russia went the wrong way by 4 years, so they lost 4 years of life expectancy on average in that period of time, in that decade. The rest of the world was gaining life expectancy, slowly. Otherwise, there was no obvious indicator that seemed to predict it. So in fact, again, work by Olivia looked at changes in life expectancy and infant mortality were probably the strongest predictors of TB trends in the UK and other countries, especially in the pre-antibiotic era, general life expectancy. So on that note, the next sort of resurgence that's of interest is this resurgence in the Aboriginal populations or Indigenous populations, mostly in Canada, but also in Alaska and in Greenland. So what you see is that, and I'll just show you the expanded view because it's sort of a little easier to see. There are three populations. So most of the Indigenous populations, the rates fell dramatically in the 60s and continued to fall into the 80s. And then in the 80s, something happened. And the rates in three Inuit populations started to rise and have continued to rise. And in the other Indigenous populations that we were following, mostly First Nations populations, they continued to fall slowly, although they remain above the Canadian average. These Inuit populations are Greenland, and one is in Quebec and the other is in former Northwest Territories. So totally different jurisdictions, different health systems, different policies, different approaches. But the one common feature, there were two common features. One was that the TB control structures were dismantled in the 1980s because TB was gone. So that was all kind of put away, the X-ray machines and whatever. Even BCG was stopped in some populations. And the other is that, in fact, the life expectancy in these populations, although it has not worsened, has not improved in these Inuit populations and remains substantially worse than the life expectancy, and the same for infant mortality, compared to the other Indigenous populations. And in Quebec, the Inuit population has a life expectancy on average 10 years less than the rest of the Quebec population. So there's very substantial differences in the life expectancy, which is a sort of general health indicator. So over and over again, life expectancy comes up as a marker of TB trends, going up, going down. What exactly that means in terms of how you model latent TB, I don't know, but I raise it as a question. And just as an example, because I'm involved as a consultant in some of these northern villages. So there was one of the villages, it's a very focal disease. So one village for over 20 years had not a single patient with TB. This is a village of less than 1,000, but about 900 people. So it's a small village. So they had nobody with TB at all for over 20 years. Nobody heard of it. Nobody knew of it. Then in 2012, one adult had active TB. 2013 was fine, quiet year. 2014, suddenly 4 people had TB, and in 2015, 20 people. So suddenly, they had an outbreak on their hands. It's the same, we've seen the same in village after village. So exactly, again, how this happens, I'm not sure. We don't actually know the status, tuberculin status, latency status, and so on in these villages at all. There's been no systematic testing. But just to say, it's a very remarkable phenomenon, these focal epidemics coming out of nowhere. So TB resurgence can certainly thwart the efforts of TB controllers, but also it's something to be kind of thought about, pondered about. Okay, so final thoughts. So underlying determinants are important, but what's unclear is how to actually have an important and lasting impact on them. Diagnosis, we have poor predictive ability, has to be accounted for. Who to treat, the highest risk and the highest population attributable fraction are usually not the same groups. Treatment, again, forget about INH. Rifamycin-based regimens are effective, still lengthy, and there's some risk. Reinfection is important to consider, but in what populations? I think the cascade of care requires consideration, both in terms of investment costs, but also in terms of complexity and feasibility. And finally, reservoirs and resurgence. Resurgence happens. We have plenty of examples. And do we really know why these resurgences happen? Sometimes we have a fair idea, but how to model what we don't exactly understand. Thank you.
Thank you, Dick. So we have about 10 minutes for questions. Rand?
Thanks. That was really interesting for that outline, particularly the bit about resurgence. And yeah, that case for the Inuit village is disturbing, almost. I guess when you talk about a reservoir, I think, is it a reservoir? I mean, when we talk about a reservoir for disease in TB, we often talk about the latent reservoirs, like who is still vulnerable to progression without a new infection. But I wonder whether here we're actually talking about the reservoir of a vulnerable population in which, as soon as TB gets just dripped into it, it just explodes. And that reservoir can be drug use, HIV, or just general poverty and these other determinants that we also know are important. So I wonder what you think, what constitutes a reservoir in this context for resurgence, is my question.
Yeah, so I think that's a very good point, is that the reservoir may be not latent TB as we think of it, but susceptibility to TB epidemics, to TB transmission, and to development of TB. And so the vulnerable populations may be, in fact, more important to consider as a mechanism of control. Now, exactly how to best to influence that vulnerability, that's less clear.
Florian, and then Tom.
Thank you for an inspiring talk. Great. So you mentioned the TB study, and I mean, a lot of people have discussed that, but what's really striking about this population is that it's a population that is highly susceptible with an extremely high contact rate as well, which tells me that even if you reduce cases as part of preventive therapy there, given this high susceptibility and contact rate, you probably do not have as much of an indirect effect compared to a scenario such as the Inuit populations. When these trials were done, that was very often done as part of this big package of interventions in the Inuit population, including case finding, including isolation of cases, including treatment of what was called inactive tuberculosis. So this was a package of interventions where you could imagine that even if people were susceptible after treatment again, you had achieved a population-level impact through these measures, including latent therapy. My question is, even though we see this resurgence of tuberculosis at the individual level after people stop their treatment, shouldn't we consider LTBI as part of a package of intervention that aims to really reduce population-level transmission?
So that's a very good point. I think you're right that the indigenous populations, that profound drop that we saw in the 60s and 70s reflected a broad group of interventions. So they were treating latent TB, BCG vaccination, X-ray screening, aggressive treatment of active disease, and probably also a fair amount of population mobilization as well. So it was a very broad effort that tackled in a multifaceted way. So I agree that going in and handing out INH for some months, and some people taking it, some not, is likely indeed to have a very limited impact. You need to be broader. But whether you can get it with only technical interventions.
Tom and
maybe.
Then Frank. Tom.
Hey, thanks very much for that. That's brilliant. It's actually a clinical question. Obviously, from your study, it was a low HIV co-infection setting. Just what would your advice be in terms of drug interactions with rifampicin if we're going to chuck out isoniazid in places where you can't monitor?
Sure. So for HIV-infected individuals, obviously the rifampin has important drug interactions. Basically, efavirenz-based regimens, there are a number of regimens that are safe and effective despite use of rifampin. Some are definitely off the table. Yeah, but it is manageable. I mean, we did have some 400 or so HIV-infected individuals in the trial.
Frank?
Thanks very much, Dick, for a great overview. And also, I think you pointed out a couple of interesting things, and one is those resurgences. Now, first, the example of the village, isn't it really simply telling us that you have a totally susceptible population by then? Because what you show is actually, if I need to give an example of a classical point source outbreak in a susceptible population, I would give your numbers: 1, 4, 20, with the serial interval in between. So it nicely shows, I think, that a case has been introduced in a completely susceptible population. So I think that's what you see. You see, it may actually be that this is a reflection of what we were discussing yesterday, that we basically don't really know very well or there is a very broad range of estimations about what the level of protection is that is afforded by previous infection. Mm-hmm. So potentially these populations had become almost TB naive. So that could be one explanation, and that could also be the explanation why you find the difference between the Tibella study and the Bethel studies, because after the Bethel studies, that's what you actually showed. These incidences went down very, very quickly. So the risk of reinfection went down very, very quickly, which is a likely reason why over this 19-year observation period, you see so few breakthrough cases. The other thing is, so that was what. The other thing is that I think that what you said about the former Soviet Union and life expectancy. That is life expectancy taking into account under 5 mortality. Under 5 mortality went up. And that probably is an explanation why life expectancy went down. Under 5 mortality by itself is one of the strongest indicators of basically poverty. It's the strongest factor in the Human Development Index. So we are apparently just looking at, and still we don't know what the mechanistic pathways from poverty to TB, and I think what you show, and that's also my own hunch with these blips during the 20th century, is that it's progression to disease rather than transmission, and I'm very, very thankful for that, because I've never seen those data from the Pepworth experiment, that it is probably not crowding. It is probably a direct effect on progression to disease. And I don't really know what my question was, but this is my reflection. So thank you for that. So it gives me a lot to do the coming night when I will be laying awake because of my jet lag.
Okay, so I'm not sure how to respond, but thank you, Frank. I'll let the next person ask a question. Yeah. The only thing I'd say is that, again, that Papworth study was fascinating because, the rate of infection was identical. And yet, despite very high rates of infection, 20, 21% per year, so in other words, everybody became infected by the age of 5, really, they still had no disease. That's what's really, so it was definitely not preventing infection based on TST and actually X-ray granulomas appearing. It was preventing disease.
Bob and then Richard.
Yeah, I'm not sure about the Papworth, but I wanted to go back to you clearly demonstrated in the villages that you did a comprehensive program going in, screening everybody, treating the people who had disease, and prophylaxing the population, was able to reduce the incidence of disease. And that's the same thing that they showed in Alaska in the early 50s. They went in, they found a lot of disease, they said, holy cow, we need to have more places to treat these people, we need to screen everybody, and they basically drove the disease away. You think it's just cost that keeps us from doing this? I mean, we actually have a way of going in and getting TB out of a community. Is it just the cost that stops us from doing this?
So, again, in the northern communities, of course, people shifted to other priorities, suicide and diabetes and who knows what all. And the funding was shifted away from TB. But yes, I think it's you spend more money on something, you should be able to at least achieve the technical control. The difficulty is if you don't fix the underlying vulnerability, then as soon as you turn your back and stop anything, the TB comes right back. And that's kind of the example from the village, is that, yes, they're susceptible. Whether they're susceptible because they don't have TB infection, but in fact, they're much more susceptible. In one village where we measured it carefully, tuberculin conversion occurred because they had been, that was a different village. 30% of people with conversion developed disease, which is way more than traditional numbers. And even the people with previously positive TST, documented, 7 or 8% developed disease. So it was less, but it's still an astoundingly high rate. So there was clearly vulnerability in terms of biologic vulnerability to disease going on.
Richard, did you have a question?
I think you've just messed up my study design. Northern communities, these isolated villages, I'm trying to work out whether we can learn anything about time to disease from them. And we need to know, and the key things I just go down, so is mobility low? What was the screening done? What was the kind of what happened next? Because if mobility is very low, might be very stable communities, only close contacts were screened, and we know a lot of transmission occurs outside of the household. Can we learn anything about time progression by watching them for the next 20 years?
So there is some, I mean, again, the one village where we kind of went into one village where there was outbreak after outbreak and we looked at housing, we looked at nutrition, we looked at everything. We couldn't find out a single, like, magic bullet. It's kind of a global vulnerability. You can't say, okay, it's bad housing, it's bad nutrition. On the other hand, what Marcel Baer was involved as the microbiologist, TB guy, so he's definitely done a lot of whole genome sequencing. So he's got quite good data on the kind of the clock. And that's actually published. I can give you the references.
Yeah. Well, so Marcel will say that this all happens in the next first 6 to 12 months, right?
So, I mean, up to 2 years was the majority, yeah.
Okay, so this is the same community, so
Yeah,
that's been published, that data.
Yeah.
Okay, I know the
I mean,
study.
one of the problems, of course, is that we were giving INH as soon as, there was naturally a bias to earlier disease because those are the ones that you found only as you screened. Once you found people that were tuberculin positive, they got INH, and that presumably prevented the disease. So it's a bit biased towards the early disease.
So I have a question, a virtual question, and then I'm going to go to Hanif and then come back to you, Daniel. So I have a virtual question from Suzanne Marks at the CDC. Do you hypothesize that malnutrition during World War I and II led to TB blips? Is it immunosuppression due to malnutrition, HIV, diabetes, other diabetes that result in the lack of control of LTBI progression to TB?
So it's felt to be, my reading is that the interpretation is that it's malnutrition. Because the worst blip, if you will, was seen in the Netherlands in World War II when there was like terrible starvation.
Before the famine, 2 years before the famine, it doesn't add up.
Doesn't add up?
Doesn't add up. It's not malnutrition.
CMV.
It's CMV, yeah.
It's what?
It's CMV. Read my paper on CMV.
CMV, oh, okay.
It's in the Journal of Implausible Hypotheses.
All right, first Hanif and then Daniel.
Thanks. It was a great talk, and obviously, but a lot of people kind of interested in blips. And I think you're probably right. Malnutrition might result in reactivation. But I suppose the thing which is interesting that it's a short blip, and that you say it doesn't turn into a more generalised phenomenon. And I suppose the way in which that would happen would be if the people that develop disease were less infectious somehow, for example, and whether they had more atypical presentations, as you might imagine immunocompromised people would do. So my question is there any evidence that during those blips that there was a greater proportion of smear-negative disease or more atypical presentations on X-rays, or has no one really looked into it in that kind of detail?
So I don't know, but Frank may know I don't know, do you know? In the Netherlands even? I don't know enough to tell. Was there more smear-negative disease or more elderly, for example, in... Mortality
data. It was mortality data.
Yeah, but is it predominantly affecting the elderly, for example?
There were two peaks. There was one in the First World War and one in the Second World War. The Netherlands was neutral in the First World War, so we were not part of the war effort. So that means that we had a large influx of refugees, especially from Belgium, which added up to about 15% of the population of the Netherlands. But that was the only thing that happened. So there was no malnutrition in the Netherlands in the First World War. So probably the peak in mortality, it has to do with other things. Obviously, part of it is the Spanish flu, which probably just added mortality to, people died earlier from tuberculosis. Otherwise, they would have died maybe the next year or the year after. Now they died from the Spanish flu. In the Second World War, that was I don't think there are such data. I've never seen them. So when there was more infections, I think the whole system was in shambles also. I think it was very difficult to do at the time. Actually, the peak of the peak was in 1946, and I think in much of Europe, that probably also had to do with the fact that there was all this migration within Europe after war. For example, large populations of Germans who had to go back into Germany after the war. So that's one of the explanations why there was such a very high TB rates in that period in Europe.
Daniel and then Richard.
Yeah, just first of all, thank you so much for the talk, as always. Just maybe two comments/question. One being, kind of like getting to the applicability of the kind of Alaskan, indigenous studies and I wonder what your thoughts are about. I mean, it's a very unique population and environment, right? I mean, basically close communities where basically everybody who would have been a contact would have been screened or, serial screening, preventive therapy, really little migration. But it's also a population where transmission are occurring in very close quarter, high transmission rate. I do think that, obviously the results are important, but I question and I would be interested in your thoughts about its generalizability to anywhere else in the world. I mean, where we simply don't have that, right? I mean, we can't even find a contact. We don't know where to go. People move around a lot. So that's the first question and comment. See what you think about generalizability, because obviously the Zero City Initiative is based upon the assumption that the Alaskan experience, being one of them, is applicable to Chennai. Mm-hmm. The second question is, you mentioned all the operational issue, and obviously you probably read the recent report from CDC, Mary Reicher's paper about where they did the contact investigation studies, and I mean that study was interesting in saying that the secondary cases they could identify basically all occurred either before the source case was detected, at the time the source case was detected, or within 3 months of the source case was detected. Mm-hmm. So 3/4 of the secondary cases suggesting that really hard to prevent. In other words, by the time that happens. So it leads me to, ask the question about what do you think about the percentage of cases that would develop after, contacts, kind of close contacts, or, do you think most of them, as some of the papers are suggesting, that really vast majority are developing in the first year or two, and that after that it's so small that, because it has implication upon what our programmatic implementation might be. Maybe we should just focus on that and not focus on the larger reservoir, for which they're very, very small. It's just two questions.
No, it's an interesting question, because the whole thing of whether, if most TB occurs soon after transmission, within the first 2 years, the highest risk, therefore your best strategy and most kind of manageable in some ways is to do close contacts, household contacts, and focus on that, especially in higher burden settings where it's difficult to imagine doing more elaborate screening, because there's a lot of programmatic advantages. You've got already the index case, you're already seeing them a lot. It's not that much more difficult to get the family. They're already kind of motivated, they're afraid, whatever. They're interested. And I think when you do the contact investigation, of course, you find those secondary cases, which are often still preclinical or at least not as advanced. So that has an advantage. And then the remainder, you can give latent TB treatment. I think it's a very interesting idea to say, what if we only treat them? That's all we do. We just go for those household contacts. We find the secondary cases and we treat all the rest. Is that enough? Will that drive rates down? In terms of the indigenous populations, we did actually analyze, because in every jurisdiction we had the years when they did different things. So these 6 populations, we had the years they did active screening, the years they did BCG. BCG came out as an important factor. When you stopped it, it was important. The second most important, though, was latent TB screening at a mass level. And mass was really, in the populations where you could find the details, they were screening 30 or 40% of the total population every year and treating everybody they found that was positive, year after year. So, of course, eventually they really, some people were tested 3-4 times in a row, and, eventually they would take the treatment and then they'd leave them alone. So it was very intensive, but often for relatively short amount of time. Again, these are, as you say, isolated communities. They would test everybody, though, or at least a high proportion, as much as they could, year after year. So very, very intensive. But I'm not sure which is, feasibility is contacts. Impact, I'm not sure.
Right, Richard, and then Joaquin.
Just picking up on, I forget actually, somebody's point. About the fact, the blips, and I need to read your paper, your implausible paper, Frank. It's very surprising, isn't it? There was this blip and no kind of the continuation of the trend. So one of the reasons why infectiousness could have been lower is, they were different in terms of their clinical manifestations, but also the fact they would have, maybe they were more likely than average to die because of the situation. So there's a shortened duration of time they're infectious, which presumably is in your paper, Frank.
All right, one last question, Joaquin.
Can I say, but it has been one of the explanations for because there is such an effect after the First World War. So you see, after 1980, you see that the decline is stronger than was expected, and one of the potential explanations is that there had, due to the Spanish flu, there had been such a massive increase in mortality of TB and thereby reduction of the total prevalence, that it led to reduced transmission over the succeeding period.
For the cases, they
and that's been, people have, I don't know what there has been a paper that looked at it, and that was, I think it was quite convincing that was the case.
All right, Joaquin.
So, hi. So I was thinking of, again, the problem of the outbreaks in these isolated communities. And I was wondering, because I think it's hard to imagine a better model of a cluster of recent transmission cases. And I was wondering, what is the relevance of the data that you are collecting for these communities from the perspective of molecular epidemiology, and to see what are the best molecular footprints in isolates to look at, to tell apart recent transmission from reactivation cases in general epidemic settings?
Okay, I'm not sure I'm completely understood the question, but Marcel Baer did whole genome sequencing, again, not in the village I was describing there, different village where they had a more prolonged resurgence for multiple years, and looked closely at these issues using, because again, the traditional RFLP kind of fingerprinting, it's all one pattern. So, but with whole genome sequencing, you kind of tease apart, when things were 2 years apart, transmission occurred, and then there was a subsequent 2 or 3 person transmission, and so on. So, yeah, most of the disease was recent transmission and occurrence of disease within a year. But again, in part, the bias there is the public health department was always trying to find the contacts and treat them before they develop disease. So naturally, everybody who developed disease, by the time they got there, if you will, that was the 6-month interval. And then everybody else would have been prevented with INH potentially. So hence there may be a bit of bias in the data.
Thanks.
All right.
Thank you, Dick.
Okay, good.